So we're recording now, Chris.
Okay. Well, good morning, everybody, and welcome to NHS Barnsley Clinical Commissioning Group. My name is Chris Millington, a governing body member. First of all, I'd like to welcome our guests, Rebecca Clark from Public Health Barnsley, who's Senior Principal, Nick Germain, our NHS support, I call him my guru friend, and Margaret Lindquist, representing Health Watch Barnsley. So welcome and good morning to you. Before I open the meeting proper, let me just try and set the scene, bearing in mind this is a meeting in public. So yes, we are holding this meeting in public. It is the Primary Care Commissioning Committee, and it's my task today to chair this meeting, which I anticipate will take just over an hour or so. Our agenda runs to almost 120 pages of information, all for assurance, but some for information and some for approval. I apologise in advance to members of the public because, as in any organisation, we tend to use jargon words, and I know Margaret Lindquist has shared this with me many times. You will hear ICS, which stands for Integrated Care System. With the ICS, we are moving towards the need to remove barriers, create seamless care, whilst acting as one team. Think of it as a one-stop shop for our health needs. That's our quest anyway. We'll do this by all of our NHS and our local partners in Barnsley working together as one team. Or you'll hear PCN. PCN, this is our primary care network, where all of our 33 GP practices have come together in geographical groups across our borough to deliver new ways of working. Our meeting today is being recorded to enable members of the public to watch what we do as commissioners sometime in the near future, if people want to access this. You will see how we arrange and look after the people of Barnsley, and you will also hear about how our executive teams working in the background are liaising on a day-by-day basis with our providers. Our providers of care are our local hospitals, York Ambulance Services, the hospice, and lots more people who go out into the community supporting people in their own homes. As commissioners, we buy and pay for the health needs or services that the people of Barnsley need. We also pay for medicines as and when appropriate. As we progress through our agenda today, some of this will come together in the form of how we are arranging and delivering care in the community. At each agenda point, our team members will introduce themselves by name, job title, and how they fit into the clinical commissioning team. Because of some of the complexity of our committee papers, our head of primary care, Julie Frampton, will condense and try and summarise the information and content. Just to note that all of the papers have already been sent to the committee members to enable them to ask or pose questions today for their own assurance and to confirm that we're in fact delivering value for money. We hope you find our meeting informative and helpful. So to agenda item 1 on our agenda, which is housekeeping. Bearing in mind we are all working in the main remote. I'm working from home, so I know where the exits are. I know if my alarm goes off, I know exactly what to do. We're supported today by Angela, our PAs, Angela Musgrave, who will scribble away and take down every single word and phrase that we say. So, Angela, any apologies?
Yes, we've got apologies from Roxanna Naylor, Chief Finance Officer,
Thank you.
Julia Burrows, Director of Public Health at Barnsley Council. And Mike informs me that he will be late because he's got another meeting he has to attend.
Okay. Right. Thank you for that. Are we for it?
We are.
Thank you. Right, first on to item 5. That's the minutes of the meeting we held on the 25th of March. What I'm looking for is this a true record? More than happy to accept any minor amendments, and then I will ask when we get to that point that we actually adopt these minutes. So first and foremost, I know you've read through these minutes, so are they a true record of that day? Yes, no dissenters, thank you. Any minor amendments required? No, okay. So can we adopt these minutes now, please? Yes, thank you. Okay. So on to item 6, matters arising. 210313 annual assurance report, that's complete now. And 200707, the GP survey. Well, we'll keep coming back to this. We've reported already quite extensively on what's happened within our GP practices. So I'm providing everybody else is content with that. I'm happy to move on. Any further questions on that? Julie.
Madwi and Julie have got, Madwi's got her hand up, and Julie as well.
I can't see Madwi. Sorry, Madwi. I can't see where your hand is up, so I apologise for that. So, Julie.
I was just going to say, I think we've done what we can do in terms of reporting on the GP survey for 2020, and obviously we'll be expecting the next GP survey to be coming along fairly soon. And again, I think it will be looking backwards and forwards to try and make sure that we keep on top of this topic and make sure that we support our practices in anything that comes out of these reports.
Indeed, yes. Madwi.
Yeah, Chris, sorry, we've missed declarations of interest, agenda item 4.
So we are. Sorry. I got notes here as well. So, Madwi, thank you for that. Thank you for dragging me back to agenda item 4. You're quite right. So I am going to formally now ask the members of the committee if they have in fact got any declarations of interest relevant to the agenda. We have concerns that, or when I say concerns, we need words and phrases, please, for item 11, which you quite rightly were coming in there, Madhavi, and 12 and 13, where in fact our GP colleagues have a direct financial interest in those 2 items. I'm more than happy that my colleagues stay. Because I'm very, very keen to get any clinical input into this program. So Madwi, yes.
Yeah, so I have a declaration of interest. Obviously, the agenda items 12 and 13 applies to all us GP colleagues, but the item 11, contractual issue reports, Dodworth Medical Centre is being discussed, so I'd like to declare interest there.
Thank you. I'm more than happy for you to sit there, Madwi. And thank you for the declaration. Can I remind everybody that it is your responsibility to declare. It's not for us or me as chair to find out. So please, if there are any further declarations over and above what we've already talked about, then let's get it recorded. Okay. So I'm taking myself back to item 5 then, which was the minutes. Is this a true record? I think it was. Any minor amendments? I didn't see anyone's hand go up. So can we adopt, please? If someone just, yes, thank you. Right. So on to item 6, matters arising. This is how I like, as you know, this is how I like to see my matters arising at any committee that I chair. Item 1 I've already covered, is complete. Item 2, Julia's already commented on. So any questions on matters arising? No, okay. So, Dr. Balash, on item 7, you're going to take us through the information contained within the ICS Primary Care Collaborative. So over to you, sir.
Okay, thanks, Chris. So the Primary Care Collaborative, I'm not going to go through this slide by slide. I'm going to assume that you've read it, and I hope that's the correct assumption. I think the question I get asked the most is why now, and what's the function of the Primary Care Collaborative going to be? So I think those are the things that people probably want to know. So one of the slides refers to why now, and I think we all know that the integrated care system is changing, and within that, the 5 places, Barnsley, Rotherham, Doncaster, Bassetlaw and Sheffield, will have place-based architecture. We'll also have an umbrella, the integrated care system, which will be the statutory body of South Yorkshire and Bassetlaw. Within that governance, there is already an acute provider collaborative, that's for the hospitals, the acute trusts. There's also a mental health collaborative or partnership which works across South Yorkshire and Bassetlaw. So it seemed odd that there wasn't a primary care collaborative at that level of governance. Essentially, the role of the primary care collaborative will be to build on the success of the things that South Yorkshire and Bassetlaw ICS Primary Care Steering Board have achieved, and those have been to try and channel the benefits of working in primary care at scale. They've been to get some consistency of approach with new initiatives that come, developments that come, and the funding that comes with them. The Primary Care Collaborative will be supported by the Primary Care Steering Board, and beyond GPs, it will be inclusive of other parts of primary care that we often forget. So that will include dentists, optometrists, pharmacists, and allied healthcare professionals. What are the benefits of working at scale as opposed to at place? There are some things that we can only achieve at scale efficiently, and a couple of good examples of those would be, if we look at South Yorkshire and Bassetlaw, how we would manage workforce. It's probably too big a thing to do efficiently at place. And again, we come back to why would we do it 5 times if we can do it efficiently with input from each place once. Another thing that comes to mind is how funding is allocated. So there's a concept of fair shares funding, but as we look at some of the bigger issues that face South Yorkshire and Bassetlaw, if you have a central governance and an umbrella organisation, it could top slice some of that funding if everybody agreed to be able to develop some things more efficiently at scale.
Yeah.
And one that probably comes to mind there, and something where we'll need some help with, is tackling health inequalities, because just as we're tasked with dealing with those at a place-based level, so the ICS is at South Yorkshire and Bassetlaw, and there may be strategies and relationships that help us deliver at place developed at the centre. The other reason for having a primary care collaborative is really for primary care not to be the recipient of directives and hand-me-downs from the centre, but to be involved right at the heart of decision making and planning at the ICS with our acute providers and our mental health providers. So that's why the collaborative is going to be there. The governance of it exists in one of these slides, and that's still tentative. We're hoping to get to a shadow period of working. It is developmental. The paper's been through a number of reiterations and had feedback, and it's been out for feedback in Barnsley to at least to primary care. We have talked about it a couple of occasions. It is going for final sign-off to the Health Executive Group of the ICS, I think on the 21st of June. So I'll stop there and happy to take any questions on the Primary Care Collaborative. So it's basically at scale, supporting place, and working out what the added value and relationships with the ICS are for primary care development. One question that just to preempt a question that does come up is, where does the community provider sit? Because we have a acute collaborative, we have a mental health collaborative, and we have primary care. And I think as this develops, primary care and community will become the one collaborative over the next year or two. So happy to take any questions on this.
Okay, thank you, Nick, for that that rundown. Any questions for Dr. Balash? Rebecca, sorry, Chris, come on in. Yes.
Yeah, just a quick one for me, if I will, Chair. So just to say that I think this approach gets best of both worlds for Barnsley patients. So the principle of local decisions will still be made at place, but where it adds value, we'll make decisions at system or work together at system. So it's not a case of place or systems. Collaborative will hopefully get us best of both worlds of working in a wider system. So I think the approach is really pragmatic, really sensible, and should achieve what we wish to achieve.
Thank you. Rebecca, I wonder if I could come to you, and Margaret, if you could just think a few steps ahead. I'd like to ask what your thoughts are in terms of Health Watch Barnsley going forward with an ICS, and in fact how when the time comes, and the time is not right at the moment, but when the time comes for Barnsley Patient Council to be presented with these things. So Rebecca, how are you cited on this situation at this moment in time?
I think the public health team are, Chris, particularly through the work in relation to the Health and Wellbeing Board and developing that health and wellbeing strategy at the place that, as Nick was referring to, that kind of place approach to health inequalities. And I think that works in development by my colleagues. I think they are well cited on that.
Jolly good. Okay, Chris, are you wanting to come back in, or is your hand still up?
I haven't got another point. Thanks, Chair. Okay,
thank you, Margaret. I'm sorry to put you on the spot so early in our meeting, but you know, within Barnsley Patient Council, it says quite clearly your voice. Well, what's your understanding now, or at what level have you got the understanding of ICS coming forward? Bear in mind, this is our journey at this moment in time, and you've heard me speak about it from time to time.
Well, as you probably know, Chris, Adrian, our chair, is very much involved at the centre of ICS, so he's keeping us fairly well informed of what's going on. I wouldn't like to say I'm an expert on this, but I'm hanging on in there.
Yeah.
I think it's going to take a lot of explaining to the Patient Council because it's so complex. But from what I see, it seems to be to the advantage of Barnsley patients.
Thank you.
That's my perception at the moment.
And you know my quest, don't you? I'm going to say it again. No boundaries, seamless care, one team, and regardless of changes, regardless of papers put together, if we can actually achieve that wonderful one team working, where there are no divisions, no boundaries, and we can actually achieve one-stop shop type of thing. And it's something that Dr. Balash put to me when I very first came into the CCG. He said, look, you know, we are getting towards care closer to home, and there may be ways of creating one-stop shops, and we looked at our lift centres with theatres in them and all sorts of things, and he took me around his own facility. So I'm still very excited in my own sweet way. The way it's quite a bit of a shock it came, and it's almost, oh no, we're not going to change things again. But everyone I speak to now seems to have got their head around it, a very positive move forward. So, Dr. Balash, thank you for taking us through that. Are there any more questions of Dr. Balash?
There's one point I'd like to make, Chris, on the governance of this, and that is that the chair of the primary care collaborative will probably be a GP. And the other reason for the collaborative to exist really is so that that GP can be supported and have a structure underneath them from across South Yorkshire and Bassetlaw, because they will most likely be the GP on the ICS statutory NHS body. So it would be not really good to have a GP who's isolated, unsupported, not representative on that body. So the primary care collaborative, into which 5 places feeds into the discussions and the chair then goes onto the statutory board, fully informed of issues, taking a consensus view and being fully supported. So it goes right to the centre of the ICS governance. With regard to Health Watch, I'll just pick up for you, Chris, very briefly. We have a health and care partnership in which each place has, I think, several members, and on there are represented the local authority, public health, and of course Health Watch as well. And I think Adrian is the Barnsley member for Health Watch. So yes. Also within that, Health Watch are represented on the Health and Wellbeing Board, which also will have representation through the local authority in the Health and Care Partnership. And also we're working on a closer relationship between the Health and Wellbeing Board and the Integrated Care Partnership Group. So essentially the voices that are needed to be represented and heard for Barnsley Place across the NHS, local authority and wider partners actually weave into this structure quite well. And I think we have to give some credit there to the Health and Wellbeing Board and to the partnership group and the people who attend and are active there in the development. It seems to me we've tied in the wider determinants of health, non-NHS organisations, the voluntary sector, much more closely into our place design than we've ever done in the past. So there is something about the channels for those voices to be heard and to be perhaps more influential than in the past. And I think that's the credit of all the people who worked hard together to develop this.
Okay, thank you, Dr. Balash. Yes, as we work through these horrible months, we have learned some very good lessons that brought us all together, and we won't forget them, that is for sure. Okay, on to agenda item 8, and if you remember in my preamble I did say that there's an awful lot of information and paper here, so I'm going to hand over to Julie Frampton, who will introduce herself and take us through 4 on the strategy group, terms of reference, delivery group, terms of reference, the project brief and the delivery model. So a lot of words, lot of paper. It's taken Julie an awful lot of hours to put this together. So, if you'd like to introduce yourself, please.
Hi everyone, I'm Julie Frampton and I'm Head of Primary Care at Barnsley CCG. Some of the work that we've been thinking about over the last few months has come about as part of the sort of the restart of primary care and other sectors following COVID, and we thought it was a good opportunity to sort of look at the various groups that were in existence sort of pre-COVID and think about how we pull that together and have really good method of working going forward, because there is a lot of work to be done and support all practices and wider community and people of Barnsley. So Chris, yes, there is lots of words. So if I take the terms of reference for the strategy group first, this is just to really describe sort of the how, why, and when of what this group is going to do and how we're going to work together and look at how we deliver a model of primary care that's resilient and reflects some of the changes that are happening because of the ICS work that's moving forward and how that looks into 2022 and beyond. We've got some key people on that group who are looking at the work for primary care, and the terms of reference sort of just describes the breadth of what we will be looking at, and how we work that through together. We've been quite keen to keep this fairly tight in terms of membership, so that we can actually move this on and use other groups around to do a bit of a touch base and sounding, and then come back to the strategy group and use that information. And we will be meeting on a monthly basis, and we have started that work. So really here is just to look at the terms of reference and approve those as a way of working.
Okay, can I stop you there?
Yeah.
Which might give you a little bit of thinking time for the next one as well. But the very first thing that the strategy group will do, it says maintain quality, safety and economic stability whilst transforming delivery. So I suppose in my business, if someone said, right, we want you to maintain quality, I would first and foremost want to know where I was. You know, where is the base? How are we going to establish, or what have we already got in place to say, well, that's where we are and that's where we're going to maintain, and then get better and better from that point.
Mm-hmm. So we have a quality improvement group that works around some of those quality issues in primary care. We produce a dashboard for practices so that they can benchmark and know where they are. We refresh that on a regular basis and take that through the quality improvement group. And now that Dr. Gunter Muckler is with us from a medical director perspective, you know, we've picked up that work and we are moving that forward. So we do have a baseline, and we do know roughly where all of our practices are. In terms of the contracts, we manage those contracts and make sure they're delivering the service specification and are delivering the services that are required for the people. So we have that mechanism. We also touch base with the Care Quality Commission around supporting practices and making sure that there's safe delivery within the terms that the Care Quality Commission work under. So there are a number of mechanisms that sit there from a quality perspective. One of the things we would need to think about is how we manage some of the services and that going forward, and look at how we could use some of the existing funding flows differently into primary care, so that when we look at delivering a different sort of primary care delivery model, that we are quite creative around the use of that finance and flow into primary care. We also then will look to make sure that we build that resilience in, and that's where sort of the primary care network comes in to support that, and the Federation, Barnsley Healthcare Federation, can support some of this on scale. So there are a number of mechanisms in there, and that's sort of reflected in the membership of the strategy groups, so that we have that across. And I think it's a way of working that we've had for a while, and this was just to refresh and relook and provide that focus so that we can continue to deliver some of this transformational change.
Okay, Julie, I purposely asked that question, bearing in mind that we are in public, and we whiz through all sorts of things, as Margaret Lundquist says, you know, that you use jargon words, you link, you know, you whiz through things, but we are in public to reassure the people of Barnsley that we do have mechanisms in place. So thank you. Dr. Balash, you want to come in?
Yeah, thanks, Chris. So just to reiterate and add a little bit to what Julie said, first of all. So the quality indicators have always been difficult in primary care because some can only be proxies. Of course, what happens between the patient intimately and their doctor is confidential. It's always difficult to measure quality. So the things that we have are the primary care dashboard, We have the CQC report that comes to this committee each month. Then we have achievement against some of the proxies. We've talked about one, medicines optimisation. Conflict of interest was described there with GPs. Actually, although that exists, it's a sustainability payment that we get that to try and sustain practice. But the biggest thing that the medicines optimisation achieves has been a massive improvement in the quality and safety of prescribing and the morbidity with poor quality of prescribing going forward for patients. So medicines optimisation is a real quality and patient safety mechanism that we have. So that's one way we measure quality achievement against that. Then the other things are we have the CCG Quality and Patient Safety Committee, which receives issues through the medical director and comes to our governing body. So that's another mechanism. The other thing is we're rated outstanding as a CCG. I don't think we would get that in the assessment if we didn't have an outstanding and fully competent, high quality primary care. We wouldn't be assured on that. So there's lots of things around quality. What I would say about that first point though, and the reason the primary care strategy group has sort of, I suppose informally it's always existed, but we've just pulled it into one. The reason for that is that as the integrated care system develops and the CCG transitions, the governing body GPs won't be there. The commissioning function is being designed. We don't know where clinical leadership will be in that, or where primary care will be, although we hope and are working towards it having a strong place. But through COVID, there's also something that the public really must be aware of, and that's the resilience and the sustainability of a primary care, which has supported the public, the people of Barnsley, through one of the blackest times that most of us can remember, through COVID. And what I would bring into the public's understanding is currently, in terms of the reset and going back to face-to-face, the profession is currently in dispute with NHS England and with the Department of Health around its understanding, appreciation and support of primary care. So primary care has been massively pressured during COVID. It's remained open for business in different ways, different technologies, but we have continued to be there. And in fact, Matt Hancock, who we were talking about earlier, described a week last Wednesday in the House of Commons as primary care being the bedrock of the NHS. So we have faced massive challenges, both for patients, keeping them safe, but also for keeping our staff safe, clinicians and wider staff. So I think primary care sustainability is a real issue.
Right.
It was before COVID, and it becomes a much bigger issue post-COVID. So this group is also looking at how we can maintain a primary care service to patients and deliver the primary care strategy of South Yorkshire and Basset Law, ICS. So it's quite an ask of this group, but it needs to be formalised and its remit clear, so that if anybody points at me or anyone else in the CCG, we can see it, say that's where our primary care thinking and matching to strategy and innovation and all the rest of it starts with.
Okay, thank you, Dr. Blah. Nick, can I bring you in very briefly, please? I did describe you as my guru who keeps me on the straight and narrow. Are you happy representing NHS England this morning? Because I know you will sit with other committees. So a very simple question: are we doing things right, and are you content that we are doing things right? Already, yeah, I've got to remind you that Dr. Balash did say we are outstanding.
Yeah, no, I definitely agree that the strategy covers it's really comprehensive and covers all of the sort of key areas of work that we would be working on for NHS England and working with CCGs on. And the sort of structure of the two groups and the terms of reference seem to be a really effective way of working. I think, like Julie says, it's refreshing and reintroducing something that was in place before and it worked before. So we're obviously assured by everything that's presented in the papers. And I've jotted a couple of things which I think are probably detail that rather than in the delivery model, it's things that the groups would work on. But and picking up on the point Nick made about it's about supporting primary care resilience and staff on the front line to deliver. So I think things like the role of the workforce head and the ICS to try and support the sort of development and the staff in those ways. The additional roles reimbursement scheme, successfully recruiting the sort of numbers that can be resourced through that, and that the skill mix of those roles meets the future population health need, which I think is covered. It's covered in the delivery model, and the detail would come from the groups and working across the ICS. And the whole system partnership project was looking at future population health need, which Barnsley CCG is involved in and working with. Population health management as a way of looking at population need, and that will be key to delivering the PCN requirements and the reducing health inequalities. So again, that's covered in the model, and the detail of work happens at place with Barnsley for that. And probably, I think Nick made the point that there's economies of scale and there's consistency with certain projects, and something like population health management, I think, would fit under that category. And then there's around digital, there's some real things that can support the working of primary care. So the electronic repeat dispensing, the See the Signs cancer referral tool. There's a new eye care referral system that's probably trying to make the most of these supports as well. So yeah, I think the papers and the strategy are really comprehensive, and the terms of reference seem effective, and it's about the work underneath those that would be delivered.
Thank you, Nick. Very comprehensive. Thank you again. Julie, you need to come back in and take us through the rest of these papers. You have.
Sorry,
Chair,
Chris.
I think Richard has a question.
Richard's hand is up.
Okay. Have you only just put your hand up, Richard? Because again, I didn't.
No, it's been up for a while. I'll go back to the old-fashioned way of doing it.
Since 9:30, Chris.
Yeah. So just a couple of things, really. Just thinking about the governance and the way that this group links into the other committees of the CCG. So we've talked a bit about quality there, and as Nick mentioned, formal responsibility for receiving assurance about primary care quality in the CCG sits with the Quality and Patient Safety Committee. So I just wondered if there needs to be something in the terms of reference about how this group will report into or inform the QPSC in terms of primary care quality. So that was one question. Then the terms of reference also talk about this group reporting progress into this committee, into the Primary Care Commissioning Committee. I just wondered what the thoughts were about how that would happen. Is that a progress report into each meeting? Is it minutes of meeting, a highlights report? And maybe does that need sort of just spelling out a little bit more, really? And I suppose the third point is that in terms of decision making around the delegated functions that we have for primary care, the Primary Care Commissioning Committee remains the decision making body for those. Mm-hmm. And again, it's implied somewhere in the terms of reference, I think, but I wondered if that needed to just be made explicit, really, that this committee continues to be the decision-making forum for the delegated responsibilities.
Okay, Richard, thank you for that. Apologies that I didn't see your hand going up anywhere. And if anybody does want to come in, there's the old wave. If in fact I can't see the automated thing, so can we leave it that you and Julie will get together on this point? Because some good points made there, Richard. Thank you. I'm
more than happy to do that. I don't think it needs radical transformations to what's there. I think broadly speaking that they're good. It's just maybe sharpening up the words in a couple of places. That's all. So I'm more than happy to do that, and then we can share an updated version with the group thereafter, perhaps.
Okay, take your hand down.
I will. Thank you.
Julie, you're still on. Come on.
I think, Nick, have you put your hand up now?
Yeah. Yeah, please. So I think in response to Richard's point, I think we've had this discussion sort of before, and I can't immediately see it here. It may be here, and that is the primary care strategy group will bring things to primary care commissioning committee, and that's the committee that signs off. That's that. But I think somewhere we said if what we bring, there's an issue with it in terms of that we get some feedback, and then rather than it being dismissed forever, we go back and look at it again, because it's because what it's putting into this group really is a wider primary care and clinical sort of piece of thoughts and development. So if something, you know, if it comes here and it's a non-runner, that's fine. But I think it's important for us to understand why, and to understand what the issues, challenges are, and to be able to have another think and resubmit it as appropriate. But I think, yeah, absolutely, this is the committee that makes the decisions, and that's why we have the separation.
Okay, thank you, Dr. Balash. No one else? I'm not missing anybody? Well, you better come back in, Julie.
Okay, so quite happy to work with Richard around some of the wording just to tighten that up. In terms of reporting, we keep brief action notes from the strategy group, but from some of the wider work, we will be managing it on more of sort of a program project management basis. So we'll probably we will bring highlight reports or exception reporting, and as Nick has said, it will be to sort of take a view, and hopefully everything will be resolved. If not, we can go back and go through that working through the strategy groups. I think it will be more on that sort of program project management basis.
Okay, right. What about the delivery group then?
Delivery group. So this is we did think about putting together quite a large group, but we felt it would be fairly unwieldy, and we would probably spend a lot more time talking than we actually did in sort of delivering those sort of work at sort of front face. So the strategy group will look and think of the various different strands of work that will need to be done, and we will set up some sort of task and finish groups, and we will monitor those through a project and program management. So the primary care delivery group will meet to make sure that those projects and deliverables are on track, and then report that into the strategy group, and that will become part of those highlight and exception reporting into PCC. So the membership is quite small, and this is to sort of ensure that we actually get on and deliver some of the work while keeping an overview on progress. So we have we've started with the PDA. So we have a PDA sort of task and finish group to get that work through for this year, and we are going to link into some existing task and finish groups rather than sort of recreate lots of new groups where it's the same sort of membership. So for instance, mental health, we're going to join what's already existing and make sure primary care is reflected in that sort of work. So the terms of reference are a lot looser, but it will be managed through the strategy group. The strategy group.
Okay. Yeah, as you note, it's looser than anything I've seen previously. So that may provoke some question a little bit in a few moments. So can we move on then, please? I'm just mindful of time, really.
So the next one is the project brief and the project plan. So this was to try and bring together everything that we were aiming to do. So the document that follows is quite a large document with lots of narrative in it, and what I wanted to try and do was have something that was fairly concise, that describes what the plan would be and what our aims, objectives and deliverables were. So that's why we have a project brief, just to try and bring something fairly concise to look at and to sort of support the delivery of the work. And then the primary care delivery model. This has lots and lots of words and narrative in it, and it describes in slightly more, well, probably in a lot more detail than the project brief. And this will form the basis of the primary care strategy that links in with the ICS primary care strategy. And as Nick was saying, this is part of those linkages into place and into system, and to make sure that we are well placed to deliver what we need to deliver for the people of Barnsley as well. This is a lot broader because we include primary care estate and digital, and you will note that there is still some work to be done to describe and expand those sections out, and part of that is because this still is quite a work in progress, and I think primarily we are looking to sort of support the return to sort of business within GP practices, and we're just wanting to take things steady and introduce things at a time that's appropriate. So there are things that we will need to build on. So I think Chris has departed from the meeting. So
he does, doesn't he? So, well, Nigel, you are the...
Nigel? Sorry. Can't be me, can it?
Yeah. Sorry, it is me, but I think Chris is back.
Is he?
I don't know. He's on my
Yes,
screen.
he is.
I know. I don't know how my computer decided to just go into a refresh, so I had to sit here and wait until it refreshed itself. So, Julie, are you now finished, or where are we?
yes, thank you.
Okay. I'll watch the recording.
Thank you.
Just one point, maybe Dr. Balash may want to come back in on this. Just reading through these terms of reference in relation to strategy and delivery, I'm mindful of the fact that we have something called Care Closer to Home Board.
Yep.
Are we in the areas of duplication here in any way, shape, or form?
Yeah, and that's really good, Chris, that you've asked that question, because it demonstrates the value of having the strategy group, because one of the topics that we discussed in detail at the last strategy group was how we linked with the Care Closer to Home Board and what the overlaps were. And so there's a piece of scoping work. So we were Swift were in the Federation, and we were looking at how we would scope what each group does, so we weren't duplicating, and where it would be helpful for the two to have a bit of overlap in membership or a discussion, perhaps in a developmental forum. So we actually picked that up. It's an obvious thing. We picked it up in the strategy group and discussed it with Jill, who I think is the chair or one of the chairs of the neighbourhood programme board, I think it's called now. Also discussed this with Jeremy, and we recognise that you can't develop primary care in isolation of what's happening in the community, and that means our community care provider, our mental health provider. So there are going to be overlaps. We're aware of that, and we've shared with other people, and we're going to make sure that we avoid duplication.
Okay.
It comes back, Chris, to what I said about the primary care collaborative, which is you can't develop primary care in isolation of community. So that collaborative might develop to be primary care, or might be just community and primary care, or just community. Yeah.
Okay. Thank you for that. Let me just, Nigel, if I go off again, because I've just had another message saying your laptop is being updated. So I know you'll do a sterling job if I disappear again, and I hope I don't. So, right, according to my little bit of piece of paper here, we're on to item 9, which is the finance update.
Chris, can I just pick up quickly? My hand's up. I'm sorry, you probably haven't seen it. I'll put it down. But there is one thing that you referred to, the terms of reference for the delivery group as looser than you've seen.
Yes.
So I think we need to address that. It's purposefully so, because the delivery group will be a variety of task and finish groups and a variable membership. I regard it more as a working group. And so you could even argue, does it need terms of reference? Because it's a working group that will report into the strategy group. And as such, its membership is going to be quite variable at different times for different things. And I think we can get hung up on, I think Julie's point is there's a lot of governance. I think the governance, probably main body of it sits with the primary care strategy group and what it reports into primary care commissioning group committee. And that's the decision-making process. The delivery group is purposefully loose because we could have spent, the potential membership is so extensive, we could have spent 2 or 3 hours just debating the membership and we would still not have had everybody in and everybody happy. I'll not labour the point, but that's purposefully so.
Right. Okay, Julie, you want to just again add in?
Yeah, I just think before we move on, Chris, we just need to ask the committee to approve the terms of reference and the project brief and the primary care delivery group.
Yes, of course. Thank you, Julie. So, voting members, please. Are there any dissenters to this, and can we approve the paper that or papers that Julie has put forward? So, first and foremost, are there any concerns, any dissenters to this at all?
Do we just record for the minutes, Chris, that the terms of reference are approved, subject to those further sort of clarifications that we discussed?
Indeed. Yes.
Yeah.
Okay. All content. Right. Well, at long last, Ruth, your time to come in to tell us about our finance update at agenda item 9.
Thank you, Chris. So the report highlights the budget requirements under the national H1 arrangements covering April to September 2021. The H1 arrangements are system funding envelopes comprising of just CCG allocations, system top-ups and COVID-19 fixed allocations. There is a shortfall of 1 million between the allocations and our budget requirements as a CCG. The allocations are based on national formula calculations, whereas the CCG budget requirements reflect commitments linked to the national GP contract, planning requirements, the primary care network contract, DES requirements, and historical increases in premises. The second half of the financial year, October 2021 to March 2022, is subject to further guidance. So the class in the second half of the year is H2, so we've got H1 and H2. The paper also highlights the annual breakdown of the primary care network contract DES financial requirements. Does anybody have any questions on the paper? And apologies for the dog that's barking.
Okay. So you have adequately covered H1 and H2 to the benefit of everyone, including the members of the public who may be looking and watching. Okay. So any questions for Ruth on this? I'm going to ask our accountable officer, Chris, to come in on this and just see if he's got any words that may assure the people of Barnsley that we are doing what we should be doing. Chris, can you just give us a few moments?
So what you're thinking, Chair, in terms of whether we'll meet our financial duties or whether we're spending our money as to get the maximum value for money?
Well, the concern, if I was a member of the public, which I have been, and still are in lots of ways, saying, "Oh, you've got £1 million shortfall," my immediate thought would be, "Well, have you got enough money to look after me, etc., etc., etc." It's one of those simple things. So,
yeah, well, NHS finance is a very complicated area to work in, and particularly in a year of COVID. So we've had a very uncertain financial year. But to put it into context, our total budget is, £450 million. So as a percentage, it's a very small percentage we're talking about. But obviously, in isolation, £1 million is a huge figure, but it's something that we can normally manage within our whole budget by being flexible between different services we commission. So that's probably the best I can do, Chair.
Okay. Any further questions for Ruth? No? Okay. Thank you, Ruth, for that. And back to Julie Frampton for agenda item 10, which is the CQC update. So, Julie.
Thank you. So the Care Quality Commission report just outlines initially the inspection process for this year. It is slightly altered this year given the move out of COVID, and we've tried to explain what that looks like as an approach for our practices. Also included in here is the practices that have had inspections recently. So you'll recall that our Rose Tree practice had quite a poor report previously, and I'm pleased to say that they've moved from inadequate to require inspection. They were inspected last week, I think it was last week, as part of the review, and we are just waiting for that report to be published. The verbal feedback we've had from the inspector at the Care Quality Commission that this looks to have really picked up and be and have improved. So we're hoping that when the final written report is available, that is reflected as we're expecting, and then we will bring that report to a future meeting. So just to note that we've been informed that Lakeside Surgery will be inspected probably sometime next month. We're not entirely sure yet, and this is an overdue inspection because of COVID. So you'll recall a little while ago, probably 1920-ish, that there was a change in contract holders at the Lakeside practice, and so they need to be inspected in respect of the change in contract holder. We've also been advised that Coty and High Street practice will be inspected. So overall their ratings are good, but they do have some subsections within the report that require improvement, and it is those subsections for both those practices that will be reviewed. We also had a remote inspection at Hoiland Medical Practice. I don't have a lot of detail on that. So this was a short notice inspection that occurred, and this was based on some information. So there was a collation of information that came into the CQC that reached a threshold where they felt that they needed to make contact with the practice. So that's what they've done. When we receive feedback from there, we will report to the next Primary Care Commissioning Committee meeting. So that sort of covers the CQC report.
Okay, any questions for Julie on this report? No, that's me.
Yeah, Chris, just very briefly, I think Julie and I discussed quite recently these remote inspections in response to information received by the CQC, and I think I don't know if you, Julie, would. I know you explained to me, but it might be helpful for the public to understand a little bit about what triggers these, because they're not routine visits. Please.
Yeah, sure. So the CQC is a regulatory body, inspects practices, acute trusts, and covers sort of NHS contracted providers. They do have a wide range of ways that members of the public or other organisations, professionals can actually reach out into the CQC and raise concerns. So there are sort of ways to do that by email, they contact us through their websites, telephone contact and whatever. So anyone, including members of the public, can contact the CQC if they have concerns. If it's an one-off type concern or complaint, that they will direct that back to the practice to deal with. But if they they get quite a number of different concerns coming from the public or from other avenues into the CQC, it reaches a bit of a threshold, and that will sort of trigger some in remote inspections in this case, but face-to-face inspections if there is other sort of causes of concerns, and it is about meeting that sort of threshold within the CQC.
Okay, thank you for that. Margaret Lindquist wants to come in. Margaret, you are muted at the moment.
Thanks for that, Chris. Just for clarification, there are 2 practices in Hoiland. Which one is this?
I keep forgetting. I'm sorry that they're known by different things locally than we think of them. So I do apologise. Let me just check. So this is Hoiland Medical Practice. So this is a Hoiland Medical Practice that's at the Hoiland Centre and has a branch at Cape Horn Medical Practice, which the lead contract holders is Dr. Wood.
So not the Waldersley practice?
No.
Thank you very much.
Pleasure.
Thank you, Margaret. Good point you've made there on behalf of the public. Okay. Any further questions? Any further queries? Nick, thank you for coming in for that extra qualification from Julie. It's important, obviously. Any questions? I don't see any hands. Okay. So on to item 11, please, which is the contractual issues report. Again, Julie, please.
Yeah. So the contractual issues report, the first item is the contract variation for Dodworth Medical Practice, Apollo Court. So that we have received a request to remove Barnsley Healthcare Federation from this contract. I think members may recall some time ago we had the previous contract holder give notice on that contract, and we went through a process and the contract transferred to Dr. Gunter Muckler and to Barnsley Healthcare Federation, and that was to make sure that we could have really good support to address some of the issues and problems that were evident when that contractual issue came to a head. Pleased to say that things have progressed really well at Dodworth, and now is a good time for Barnsley Healthcare Federation to take that step back and to allow the practice to run with the GPs that will become the lead contract holders. That was always the plan, so I'm really pleased that we're at a point where that can happen. This will be done by a contract variation in line with the policy guidance manual, and really just to note that we have also been approached as a next step to merge Dodworth Medical Practice with the Grove Medical Practice, so that becomes one which will be much easier to manage for the contract holders. So that's the first point on there. And just to note that Penistone Group Practice, one of their GPs, has been through a 24-hour retirement, and this is around triggering their NHS pension elements, and this is just to note that this has occurred. So do you want me to stop there before I go on to the next item on there?
Oh, no, keep going, Julie.
Perfect.
We'll cover each item when we get to the ask, and I'll take people through the ask if I may. Yeah, sure. So the next item is around the GMS PMS equalisation. So this this is a process that started some years ago, and members will recall that last year and the year before we talked about making sure that the payments to practices were equalised and evened out, so that there was a fair payment mechanism in place for all of our practices. Last year we did achieve equalisation, and was quite a major achievement, which we were all pleased with. Pleased
to note this year we are still at that equalisation, so we will be applying the uplifts as required, which takes the payment to £96.78 per patient. So you'll note that from June those uplifts will be applied to the contracts.
So the final payment will be what, Julie?
96.78. And Ruth, if that's the wrong thing, tell me, but I'm pretty sure that that's the right thing.
I was just going to double check, but yeah, it does sound around the right figure.
Yeah, I looked in the paper this morning on the website, but I just did it hastily, and I just want to make sure that I quoted the right thing from the right year.
Okay, just going through the papers over the last week, I was just a little bit concerned that I couldn't see any final figure, because from memory we've normally put that actual payment final figure in. So thank you for that, Julie, and I know Angela will reflect that in the minutes. So if you want to move on, if there's no questions. So if you want to move on, Julie,
Yeah.
to contract.
Yeah, so item 3 is just to note that we held an extraordinary meeting of the Primary Care Commissioning Committee to look at the home visiting contract extension that Barnsley Healthcare Federation have, and that contract extension was approved through a single tender waiver. So this is here just to note for the public that we still have that contract in place, and that will support general practice and help with some of the will reduce some of the workload as they tackle the ask of returning to business as usual in primary care.
Okay.
And the next one is around the online consultation platform, Dr. Link. We currently contract with Dr. Link. We went through a South Yorkshire and Bassett law-wide procurement process. Rotherham had their own consultation platform at the time, so they didn't join in that, but the rest of the CCG did. It was a 2-year contract that commenced in September 2019. So all our practices have this installed, but there's only one practice that fully uses all of the aspects of that platform. And as the paper says, 5 of our practices are connected, and but only 4 of them actually use that. And I did put in the description of what connected and unconnected means. The purpose of bringing this here today is that with other systems that have come along since the Dr. Link contract, we feel that it's probably not a good thing to extend or re-procure with Dr. Link, and to go out to general practice to find the system that they would prefer to use. Quite a lot of our GPs are using AccuRx and find that far more easier to use and find it a bit more user friendly than Dr. Link. So this is just to note that once this contract comes to an end at the 31st of August, we will not be renewing it, and we just want Primary Care Commission Committee to be aware of that.
Okay.
Do you want me to do the last one, Chris?
Yes, please. And then Mike, let's bring Mike in. Mike Sims wants to come in. So let's come in, Mike. If you've got a
I mean, about costing of AccuRx, because initially this was free, and then there's been various offers, I think, from the company about pricing, and then changing the pricing, and I think they tried to make a real killing and then had to stand back from it. I just wondered where we were now, because the actual pricing of AccuRx seems to be remarkably opaque.
Yes, so that's they did sort of come in and swoop the market very, very rapidly. and quite a lot of their functionality was free to general practice. So in the interim, there's been quite a lot of work done with getting them on the provider framework and coming in line with other platforms that exist that offer the same options. What we have done on an ICS basis is work with AccuRx around getting a much better value for money pricing. So we have extended those contracts till March 2022 in the combination of Digital First primary care funding and NHS digital funding. And we've also then added on an additional support to practices to use bulk SMS text messaging and use of various different what's called florries, and they help the practices to support things like blood pressure at home and getting all their data and things like that. So that is in place until March 2022. We will need to go through a probable mini procurement process to make sure that we've got an online consultation option, and that's currently being explored at the moment because the rest of the CCGs and SYB have the same contract end date with Dr. Link. There has been absolute value in exploring that with sort of on an ICS footprint, because there has actually been some significant cost savings on doing it on that footprint, which has been helpful for all of us.
All right, Julie, you've covered an awful lot there, so thank you. What we've got now, the ask of the committee is one approval and 1, 2, 3, 4, 5 items to know.
So shall I just go through item 5, Chris, before you?
Yeah.
So part of our work in contract management has been with Barnsley Healthcare Federation, and we have had quite a number of issues with some of the reporting and the data quality and various bits and pieces. We also did an incredible light touch with our federation and their contracts, as we did with other providers through COVID. We had discussions and meetings with Barnsley Healthcare Federation as we restarted full sort of contract meetings and asked for reconciliation of all outstanding issues to the 2021 contract, and so we could start 2021-22 afresh on a clear footing. Unfortunately, the quality report that was submitted was still full of the same errors and late getting to us. Currently, we have 6 pages of matters arising that need to be addressed, and we are working with the Federation to try and sort out those historic issues. And also, unfortunately, the report we received for the start of the financial year was also inaccurate and had some data quality issues. So we are working very closely with Barnsley Healthcare Federation to resolve all of those issues and to get that reconciled without having to look at sort of contractual breach notices. So this is just here to assure the committee that we are managing those contracts as required.
Nigel, yes.
Yeah, thanks for that, Julie. I just wondered how confident you were, given that it's been a while that these errors have been notified, how confident you were that they'll be resolved in a timely manner. And I'll let you find time rather than me.
Yeah, so at the contract meeting at the beginning of, I think, second week in May, we had this as the only agenda item on the contract, and we went through the matters arising, and we've had agreement with the Federation that they were going to put specific time in place to resolve all of those issues, and that Terry from my team would support where needed, so that would all be done and reconciled to come to the June's contract meeting. We also asked that they review the report for April 20, which was like the first month. We didn't review May's because obviously it wasn't, we didn't receive it in time, but we have asked for all of that to be done. I'm hopeful that has been done, but I do acknowledge that there is a significant amount of work to be done to actually get that reconciled, but I'm hopeful that it will be done for June.
Okay, thanks for that. I guess I just ask that comes back to the next meeting.
Yes.
Indeed, yeah. Yeah, of all the reports that we've had, they've all been positive. There's more than a negative sort of slant on this at the moment. And Julie, I'm sure you will put your hand up to whoever you need to do to get some help and support in getting this particular outstanding item sorted. So I'll leave it at that for the time. Nigel, thank you for coming in. It was a question I certainly was going to ask.
So Mike has a question, Chair.
I mean, just to carry on from Nigel, really, I think, you know, if you've got that number of pages of matters arising with late reports and inaccurate data, I think the words reassurance or assurance for this committee are, maybe the word alarm should be more appropriate.
Yeah,
I mean, I think to put assurance down is perhaps the wrong word, and we ought to replace that in the minutes.
Yes, I would agree with you, Mike. I suppose in mitigation, which is not my job to do really, but I'm going to say it. But in mitigation, our federation have done some fantastic work for us during these very, very hard times. If we're producing paper, it's all about pace and getting things done. And I've already said very early in the meeting, every committee that I chair, I try to put some real pressure on people to get my matters arising as complete. So, well, what more can we say? Nigel, thank you. Mike, thank you. Julie, whatever, I'll say again, whatever you need to do, I'm sure you will put up your hand to the right people to try and, well, not to try, but to get this resolved. It's no good. It's just got to happen. Mm-hmm. So the ask of the committee is to approve the removal of Barnsley Healthcare Federation from the Dodworth Medical Practice Apollo Court contract. Any dissenters to that?
Chris,
no.
my hand's up. I'm not a dissenter, but I think it's really important in the context of Apollo Court and what's just been said about the Federation, that we have a bit of an accurate perspective around Apollo Court. This was something members of the committee will remember for 2 or 3 years was coming back with massive dissatisfaction from the public of Dodworth about Apollo Court medical services. And we had different people do the contract. One of the things that happened is that Dr. Gunter Muckler and partners made a relationship, developed one with the Barnsley Healthcare Federation, and they went into joint partnership. And what we have now is something that's rated as CQC good, developed and delivering a fantastic service for the people of Dodworth, which wasn't there before. Right. And not only that, the relationship and the diligence of Dr. Gunter Muckler. I'm not trying to embarrass Madney, but it's true. The diligence of her partnership and the relationship with the Federation has actually saved lives in Barnsley, because they used Apollo Court as a COVID vaccination site. Right. And were up and running while other places were looking and thinking about what to do. So there is something about having a strong GP Federation in Barnsley supporting our public and our practices. And so, not dissenting at all, but I just think we need to cast our minds back to when we were in a very difficult position with the previous contract holders of medical services in Dodworth. I think that just needs to be recognised, and I think we should say a thank you actually to Dr. Gunter Muckle and the Federation for the work they've done, not only for the patients in Dodworth, but for the whole public of Barnsley during the COVID vaccination programme. And that might just be why they're a little bit late with reports, but I don't know.
Yeah, Nick, you're quite right, and thank you for bringing that up. I do know our Director of Public Health actually congratulated Madhvi and her team on how she very, very quickly turned around Apollo Court with the help and assistance of the Federation. We know that we've got a very good Federation. We know that we've got a strong Federation. I've already said, not by way of mitigation, but the fact that they have done a fantastic job in terms of delivering COVID-19 across Barnsley. So it's not an excuse, but Mike, come on in.
Yeah, I was about to put my hand down because everybody said what I was going to say. I think, you know, basically healthcare at Apollo Court had collapsed, and I think it's a great feather in the Federation's camp, and Madhvi especially, that it's as good as it is now, and I think that needs recording and minuting.
Absolutely, thank you. Okay, I do really want to move on, and but thank you for the input from everybody on that. We've got to know the 24-hour retirement request for Dr. Morris at the Penistone Group Practice. All content with that. Okay, note the contractual uplifts and the equalisation of GMS, PMS contractual payments, and Julie has already noted the final payments where they are. Note the approval of the single tender waiver for the home visiting service contract to the 31st of March. All content with that.
Just one thing, Chris, if I can just go back to the levelling up. And again, members of the committee will remember, and this is to say thank you to Julie and her team, because it wasn't merely a levelling up between PMS and GMS. There was also some levelling down to do, which is much more difficult in my experience. And so they've managed to achieve that as well. So I would say thank you to Julie and the primary care team for doing that. We're all at the same level now. It's quite an achievement.
Good, thank you. Well done, Julie.
Thank you very much, everyone.
So I've covered item 3. Item 4, note the cessation of a Dr. Link contract from the 31st of August 2021. And note the contract review discussion with Barnsley Healthcare Federation, which we've already covered for assurance. So any more input into this particular paper? Are we content and can we move on? Okay. Margaret, your little link keeps flashing at me. You're not, are you trying to come in or?
No.
Okay, right, fine. I don't keep you out of the loop. Right, on to item 12 then, and this on my agenda says assurance, but in fact it's for approval. Chris Lawson, if you'd like to come in and introduce yourself and tell people of Barnsley what exactly you do within the fantastic job that you do within the CCG.
I'm just ringing her to ask her to join the meeting now, Chris.
Right. I thought I'd got her in there actually, see as a guest.
No, she asked me to ring her when it was her turn on the agenda, which I'm just doing now.
Okay. So if she's not responding, Angela, then I'll move on to 13 if people are content and come back to 12.
Yeah, it's still ringing and I've sent her an email. An email asking her to join.
Okay.
So no doubt. Oh, is this her coming on now? No, there was no response. So if you want to go on to agenda item 13, Chris, and then I'll keep trying, Chris Lawson.
Okay, so on to agenda item 13. There's someone called Julie Frampton is going to cover this for us. So Julie.
I thought this would be Richard doing Risk and Governance, Chair.
No, we're on to...
It's the COVID expansion.
Oh, sorry, I've scrolled on too far. Sorry. Yes, the COVID expansion fund, many apologies. So you'll recall that we brought a paper to committee towards the end of last financial year with support for practices around 7 major asks that went out to primary care. This year, we were informed that via another letter that there was more COVID expansion fund funding available for practices from April to September this year. So this paper is just to outline that there is the similar asks from the original paper, which we will be working with practices to understand and deliver. We will also be moving that funding across, so it's a slightly different process this year because there is a reducing amount of funding over the months between April and September. The CCG hasn't yet received that allocation into the finance team to work that through. When it arrives, we will get it out to practice as soon as possible. So this is just to ask PCC to approve the principles of the delivery for the COVID expansion fund and be assured that we will make sure that the finance follows when it is received into the CCG.
Okay, so you're asking us to approve the principle. Are we comfortable with that?
Yeah,
I think it's the same asks as of the original letter, so it's just to build on it and expand on, and then we will make sure that the funding follows.
Okay, Nick,
yeah, just to comment, it's a consistent approach that other CCGs are taking, where there's some level of assurance about how the funding might be used, but it's light touch. So it's the principles are consistent for South Yorkshire.
Okay, so you've all read the papers, you've heard what Julie's had to say, so are we happy to approve this? Yes, nodding, yes, thank you. Right, Angela, where are we in relation to Chris Lawson then?
Well, I keep bringing her.
I'm here, sorry.
Oh, you're there now, Chris?
I only just got that ring then. I did come in once before and, oh, sorry, I'm not on camera. I did come in once before and I think Julie was doing an item, so I have to pop back. I'm just chairing another meeting. That's where I am. Can
you put your camera on, Chris?
I've got my camera on. Is it showing?
I can see you now. Right. No, the reason why I launched into it straight away, Chris, because I'd got you in early, so yeah. You'd obviously come in and gone back out again.
Well, I came in at 9:30 and then I think I stuck around for about half an hour, but I had to go off and chair a meeting then. So I'm here now anyway. And
so Chris, what I'd like you to do is to introduce yourself to the people of Barnsley and tell them what a fantastic. I've already said what a fantastic job you do, so I'm going to say it yet again.
Got a lot to live up to now, haven't I, Chris? So I'm Chris Lawson, Head of Medicines Optimisation for the CCG, but I also work sort of, I suppose, across and into the PCN now as well. So we're sort of, we're working as an integrated pharmacy team across Barnsley, across the GP practices. So I think that's all, isn't it? So if I could actually focus on the paper, I do apologise. I think you've got a couple of versions of the paper, so it is the latest version. So when I'll take the paper as read, but just to explain a little bit of the background, and I think probably, I don't know how many of you were on this committee in previous years, so you may have seen this section of the PDA before, but we have a constant change in evidence base around medicines. There's constant developments and changes around medicines, and we've got significant risks associated with medicines and medicines usage as well. So there is a need, and it's increasing every year, year on year, massive need to actually review more patients in order to reduce the risk for them. So if they're older patients, to get them off medicines that are no longer benefiting them, and if their needs change in terms of their stability changes, we need to sort of get them off medicines that might be doing some harm. And then also we need to try and offer them the medicines that they may need, where the evidence base has come on new medicines, new therapies that can help them. So the most appropriate medicines, we want to have them on that they're getting the best outcomes. Now, there's also new systems that are coming in. So we've got electronic systems. I don't know how many of you got the NHS app now, but you know, we've got ordering, improved ordering, and we also are aware that there are certain pockets of patients that actually require more support in ordering the medicines. So we try to reach out to those. So we've got that changing population as well as the change in the evidence base and the medicines available. So for many, many years, we've had a medicines optimization sort of work program that's gone on, that's been incentivized for practices to actually pick up and undertake that extra work, and we support them as a team in order to do this, but it is an enormous amount of work. I was just in a meeting, and just this month, and we haven't even started this work, there has been something like 7,000 interventions and contacts with patients from all of the pharmacy team, and that doesn't include all the GP interventions either. So this is enormous amount of work. So the scheme you've got, this is part of the practice delivery agreement. The other part of the agreement is actually being worked up. If I could just focus on around the significant benefits of this work. So one part of it is around the reviewing patients that I've talked about, but there are some other bits. There are 3 service elements to this as well. So it's supporting patients with anticoagulation that require monitoring. There's also the something we have called Eclipse Radar. It's a safety alerting system. So it identifies people who are potentially at medicines risk and flags them for review. And it gives us a window and opportunity to actually go in there and change things, improve things for those patients, improve outcomes for the patients. And then thirdly, we have a specialist drug service. So this is the move from specialist medicines being patients having to go into hospital to get their specialist medicines in terms of outpatient appointments, where that activity moves through to primary care, to the GP practices. And we have seen a massive shift during COVID. So where patients would be going into hospital and getting their bloods and getting their salted of these medicines, they're now going into the GP practice to get that. So the funding for this part of the scheme supports all that work. It does deliver some efficiency. And so in the balance, we're looking, and I'll talk about broad figures now, and Ruth will probably come in, we're looking at 2.4 million investment in this for around 500 to 600k of that 2.4 million is around those services that we don't manage we don't measure the outcomes from. So around about 1.6 million, something like that, is investment. For that, we have a minimum measure. We've got a target of 3.5 million efficiency savings that are actually delivered. So as well as doing all that enormous good, it actually delivers and improves the financial position for Barnsley as well. And I'll open it up for any comments, anything anybody wants to raise.
Okay, bearing in mind that most of you are very, very close to this. Probably I wasn't expecting too many questions, Chris, but from my point of view, as a lay member, I'm very motivated by the words that where you say significant benefits. I'm motivated by the special drug services, i.e. out of hospital, which is cutting down the to and fro of people, because at the end of the day, some of these things probably took about 10-15 minutes. I don't know, but you go to hospital, you park your car, you find this, all of that is a major benefit to me, to my colleagues, to my neighbours. So thank you for that. Nick, you wanted to come in, Nick Germain.
Hi, just quickly. Hi, Chris. It's Nick Germain from NHS England Primary Care Team. I just had a quick question. I think you might have sort of ticked it off anyway, but I was thinking, how does this fit alongside the structured medication review and optimization within the PCN DARES? Because that's come in more recently, whereas this is more long-standing. So but I know you said you work as an integrated pharmacy team with PCNs.
So we, as you're aware, and I'll just inform because all the members. So we've got a couple of primary care network DESers that are actually being implemented by the primary care networks. One of them is enhanced health and care homes, so improving outcomes for patients in care homes. The other is undertaking structured med reviews. The enhanced health and care homes actually includes an element of structured med reviews being focused on care home residents as well. So we're working with, these are dependent upon the recruitment of additional roles by the primary care networks. So there is some challenge around the funding in terms of there being Band 7 posts that funding is coming in for. And in order to undertake structured med reviews, you actually do need highly specialised pharmacists who have a lot of experience and have been accredited by CPPE, by the professional body. The professional education body. So we are working with the PCN, that the PCN, as they're recruiting what are the Band 7 sort of more junior posts, we are actually releasing up some of the more experienced pharmacists to actually undertake those reviews. But the targets for the structured med reviews in that DES are linked with the capacity. So at the moment they recruited 3 pharmacists over the whole of Barnsley. It's not a lot. Technicians, we've gone out again for recruitment, but we are trying to look at ways where we can actually increase the numbers of pharmacists actually recruited through that PCN scheme. But it is separate work. It is kept separate, and like I say, we don't measure it. We are measuring what we're getting out of structured med reviews, but we're looking at it separately. Does that help?
Yeah, thank you. Yeah, that's great.
Nick, before you go, I'm going to put you back on the spot here, because in terms of jargon, you came out with PCN DES.
Oh, sorry.
I think it was me. Yeah. Primary care network.
I did say primary care network, Chris. I did say primary care network, didn't I? Direct enhanced service. Yeah.
So bear in mind that we are still in public, and as brief as you can, Nick. PCN DES. What on earth does that mean to the people of Barnsley?
Yeah, so it's a direct enhanced service. It's services that practices have come together as primary care networks to deliver. combine and deliver. So there's it's been a couple of years now, and the different requirements are added each year to try and build up the working of the primary care networks. And one of those is structured medication review and optimization. Julie, you want to come in?
Yeah, I think it's just to say that there is only the one DES, but there are a number of service specifications that sit underneath that. Just so Chris was talking about the structured medication reviews and the enhanced health and care homes. They're sort of service specifications rather than an additional directed enhanced service. So they sit as part of that deliverable. So it's a bit complicated because it's various different layers of delivery within that one contract.
Okay, any questions first and foremost for Chris Lawson on this presentation?
Can I just ask, because I was seeking approval for the finance for the budget, Chris?
Okay, so Chris is asking for money.
The investment.
Well, yes. So from the voting members of the committee, are you happy to approve the monies that Chris Lawson is asking for? Any dissenters to that at all? No, we've got our fingers up from our accountable officer. So thank you. So take that as approved, Chris, and the minutes will reflect that. So thank you for coming on. If there's no more questions for Chris, you can go back to your other 49 meetings, Chris, because I know you're a very, very busy lady. So thank you.
Thank you. All right. Bye-bye. Bye.
Bye-bye, Chris. Right. We're not running to Millington time today, I can tell you. So item 14, Richard, the risk and governance report, if we may.
Yeah, I'll take this report as read, Chris. It's the usual update for the committee on the risks that we're responsible for in relation on the assurance framework and the corporate risk register. It's there, as I say, for assurance. There are no recommendations for new risks or for significant changes to the risks that we've got on there. The one that I would just draw to the committee's attention is the risk reference 1410 on the risk register, which is relating to primary care workforce. We've had a couple of conversations about that over sort of recent meetings, and it was felt that the sort of wording around that risk might need tweaking to make it more relevant to the challenges that we're currently facing, particularly with respect to recruitment into these additional roles that Chris, for example, was talking about a moment ago. So Julie and myself have had a look at the wording there and have made some tweaks, so it's now more clearly focused on that as the big challenge for us going forward. But at present, there's no actual proposal to change the score relating to that risk as we just wait to see how that progresses over the next few months. Other than that, the report is just there for noting and for assurance.
Okay, well, there was a query again when I was reading these papers a few days ago, which required a sort of a conversation between yourself and Julie. So you've confirmed that that's already taking place. So thank you for that. So, Mike, if you want to come in.
I mean, the news in the last 24 hours have been full of the surge in patients seeing GPs. I mean, has that been reflected locally? And what effect does that have on the GP resilience long term?
Who's going to pick that up?
Nick.
In relation to demand and the process of so-called normalisation or exit from COVID, is that the question?
Well, but there's been, I mean, the papers in the last 24 hours have been full of the surge in number of patients booking appointments with GPs and the pressure that's producing.
Yeah, so this has been going on for, this is picked up. There was a letter from Nikki Kanani and Ed Waller from NHS England telling us to go back to face-to-face. And it was clear from the letter that it hadn't been discussed with the profession and that they had little sensitivity or understanding as to what was happening in primary care. So this is being picked up by the BMA, who've asked for the resignation of some people at NHS England. Not sure whether that's so that's what they've done, that's their action. I think for us, we are busy locally, and I think this is now being recognised. It's been recognised at South Yorkshire and Bassett Law. We discussed it yesterday at the ICS Primary Care Steering Board. It's also being picked up now by the BMA and others, and there's strong support within the ICS to support primary care manage this workload. I think there's also comms to go out around it. It's not just primary care. I think that's another point. It's not just general practice. It's also community services, and it is also the hospital. A&E are busy as well. So there's something about managing messages to patients, assuring patients, and obviously there are new ways of working, and some patients will need to adapt and understand those as appropriate. But we are introducing more face-to-face appointments, but recognising that patients can be seen in a range of ways, and some of those are more effective. So there is some messaging around that. In terms of the risk and additional roles and capacity, there are issues around capacity. Even if you do training, you have to get backfill while those people are out. Additionally, you have to have mentorship within the practice. It all eats into capacity. So this isn't just even a question of money. It's a question of people in the system, managing the demand safely, assuring the public, and again, as Mike has said, managing that the services remain sustainable. The other thing that's been in the media has been the number of nurses, doctors, dentists as well, who are getting close to the edge in terms of wishing to carry on, particularly those who have an option of retirement. So it's not unique to Barnsley. It's a national issue, and I think it's being picked up nationally, and it's also being picked up by South Yorkshire and Bassett Law and ICS and the Primary Care Steering Board, who are doing. I think we're doing our best to help the situation, but it's not a knee-jerk response. It's not overnight. It needs a calm, level-headed thinking, and it needs the support of the public. So part of that is the public understanding the pressures that the health service is currently under. Yeah, so I think that's what's being done, but no quick fix. And I think patients will continue to be managed by primary care and community care and mental health and the acute in a sensitive, proportionate and appropriate way to keep them safe.
Thank you, Nick. I think that clarifies it very well.
Well, I think the other thing is there's no immediate, quick, simple action that can deal with the aftermath of 18 months of COVID and the future of COVID. So again, some of that is messaging and in partnership with the public, getting to a place that's safe and the public can feel assured with.
Okay. Any more questions or queries in relation to our risk register for Richard? No? Okay. What I'm going to do now is actually skip over agenda item 15 and come back to it. So agenda item 16 is, have we had any questions from the general public?
No.
Okay. Now I'm going to take the opportunity then to go back to Rebecca Clark, and as chair of this committee, Rebecca, are you happy? Are you content? Have you been assured? Is there anything that you would now like to add into this committee in relation to Public Health Barnsley?
Got nothing further to add, Chris, part to say, but it's been incredibly helpful to listen to the conversation today. I'm not a regular attender at this meeting, but I feel that I'm much more up to date and up to speed with some of the developments in primary care as a result of attending today. So thank you.
Okay, I'm going to hold. I'm going to, Nick. You know, you're right, Margaret. Again, putting you on the spot in relation to what you've heard and the points that we've been through this morning, Margaret. Are you able to go back to Health Watch Barnsley and assure the chair there and your colleagues that what we're doing is somewhere near right? I don't think Margaret's left us, but she's not coming back to me. So Nick, come back then.
Okay, so it was a point on public health and primary care, and it's just that in the past couple of weeks we're exploring doing some work with our primary care networks around Andy Snell as a public health registrar, working with him, and we've had a bit of a chat about how we might help the health inequalities agenda, and she's going to, I think it's just an exploratory discussion, do some work between public health and primary care to look at how the primary care networks can contribute to decreasing health inequalities, because there are, under the DES, 4 new service specifications coming in aimed largely at decreasing health inequalities. So that's a really positive thing, working with public health. And also to say, in terms of working with the public health locally, Julia, her team, Andy Snell, everybody, there seems to be, in terms of partnership working, in terms of the agenda of tackling health inequalities and population health management, that seems to be what I think is a very positive, strong relationship being developed. And that's really encouraging in terms of long-term outcomes for patients and people in Barnsley.
Indeed, it is.
I think Rebecca would agree. Yeah. Thank you.
Margaret, are you coming back in at me now?
Yes. First of all, would I dare criticise you, Chris? I've been pleasantly surprised at how clear and comprehensible this meeting has been. I looked at the papers and thought, I'm going to be way out of my depth here. But I have actually managed to understand most of what's been said, and I will certainly be able to feed it back to Health Watch. I would also, with the last item, most of the comments that are coming through to Health Watch at the moment do relate to problems with accessing primary care. So there does seem to be an issue there.
Okay, Margaret, I in separate meetings, I've been challenged, and as a partner governor at the hospital, I've been challenged in relation to access into primary care. But I was able to talk about the positives of what's gone on over almost a 12-month period, going from February to March, whereby 1,427,000 people somehow, somewhere managed to get through to our GP practices.
Yeah.
So it is what I call a distress purchase, and clearly when you pick up the phone to speak to your doctor, you want immediate attention. It's not always possible. So the real positive, as far as I'm concerned, is that we have managed one way or another to see people, and we've managed to pick up the phone to 1,427,000 people within almost a 12-month period in time. So I'm glad that we've tried to remove some of the jargon, Margaret, and I'm assured that you will say that we are doing our very best for the people of Barnsley in relation to your statutory requirements as Health Barnsley. So thank you.
Could I also say, Chris, that my experience of primary care has been totally positive over the last 12 months.
Thank you, Margaret. Thank you. Okay, back to item 15 then, conduct of the meeting. Everybody happy that they got the papers in good time so they could review them? Yeah, okay. Any areas for additional assurance? I think we had a good meeting, and that Nick Balash wants to come back in again.
Yeah, I do. I must have had something funny for dinner last night, Chris. But I think in terms of jargon, I've just got to pick this up with you, Chris, because to Margaret's point, your point, and to the public that may be watching this, I think even the chair of today's meeting referred to H1 and H2, which I think mean first half and second half of the year, but sound more like a high-speed train.
Well, that's interesting you should say that, Nick, because in my pre-meeting with Ruth I did say to her, Ruth, what on earth is H1 and H2? Because it's, if you recall, Ruth does deliver her papers very quickly, and I said it's almost like an H2 delivery that's going into the tunnel. So she did promise that she would in fact labour on the fact of H1 and H2. So thank you, Nick. Thank you. Any training needs? No. Okay, thank you. So Richard, help me out here. In terms of item 17, anything we need escalating to the governing body, and Nigel, normally you have a little bit of say on that, or Mike. So is there anything that we need to escalate to the governing body?
I'm not sure there's anything we need to. I suppose the question for the committee is which items we would want to particularly draw to governing body's attention. I thought the stuff about item 8 and the primary care strategy and the work that's going on around that is probably something that might be worth sort of highlighting for the governing body.
Okay.
I don't. That was the main one for me. I don't know if other members have other things they would like to highlight.
I suppose just the approval of the PD medicines optimisation, because that went to governing body and then's been brought here. So I think to finish the loop on that one. Yeah.
Okay, thank you. I'm sure Angela will have picked that up. So finally, the date of our next meeting is Thursday, the 29th of July at 9:30 via MS Teams. And it's incumbent on me now to read the following statement that representatives of the press and other members of the public be excluded from the remainder of this meeting due to the confidential nature of the business to be transacted, public on which would be prejudicial to the public interest. Section 1 brackets 2 public bodies admission to meetings Act 1960. So I will now officially close this meeting. If in fact we can come back as a committee, please, at in 5 minutes time, give you a comfort break so we can continue our private meeting if everybody's happy with that. Yeah, okay, we need to come out of this